So Ryan's very nicely set the scene for my talk by talking about the burden of latent TB, and I'm very interested to hear that it's going to be 23, not 33, so only 10 out, but still a lot of people. So I'm going to talk about ending latent TB, and I'm really going to divide up the talk by talking about what we need to think about with respect to low transmission settings, and then what we need to think about with respect to high transmission settings, because I think they're a little bit different. And as Ryan says, we've got very ambitious targets. The HIV world has got lots of 90s, so we have to have some 90s as well to aspire to. But as Ryan has said, at the moment, even though overall TB is falling globally, it's falling much more slowly than is going to be needed. And if we're going to get to these targets, addressing the very big burden of latent TB is going to be an important part of that. And when talking about TB and how we might intervene, I quite like to use this diagram, which is from Peter Godfrey Fawcett, just to illustrate the cycle of how TB is maintained within a population. So here you've got a person who's got infectious TB, they've got MTB in their sputum, and that's transmitted to other people, and as Ryan said, maybe a slightly fewer than we've got here. But on average, a person with infectious TB during their infectious lifetime, if you like, will transmit to a certain number of other people, most of whom will remain healthy, will have latent TB, but will not develop active disease during their lifetime. But those who are HIV positive or have other types of immune suppression are much more likely to go on to reactivate. And the people who reactivate, some of them will have non-infectious TB, and some of them will be infectious and thus then continue that cycle. So if we want to think about breaking the cycle, there are really two places that we can intervene in the big picture. We can think about preventing infection, perhaps by identifying people who've got infectious disease earlier and then getting them onto treatment so they're not infectious. Or alternatively, and now this is what I'm going to talk about, is about thinking about those people who have latent infection and think about how can we prevent them from going on to become diseased, obviously experiencing morbidity and potentially mortality, and also transmitting to other people. So first of all, thinking about low transmission settings, and this is Cumbria, which is where I come from, where there's probably not a whole lot of TB transmission going on. So in that sort of setting, people with infectious TB are rare, and so the majority of new disease is going to arise as a consequence of reactivation of latent infection. And WHO is really very much focusing more on this issue now, and so we've got this framework towards TB elimination in low incidence countries. We've got 8 priority actions, and screening for LTBI, latent TB infection, and selected high-risk groups, and providing appropriate treatment is one of those priority actions. And then supporting that, for the first time, we've got these guidelines, came out last year, and these are guidelines on the management of latent TB infection aimed at low incidence settings. That's the first time that those have been there. So there's clearly political commitment to do something about this. So if we're thinking about addressing this burden of latent TB, first step is that we need to diagnose it. And so thinking about, before we get on to what's new, let's think first about what's old. So we have TST, which is definitely old. It does have advantages. It is relatively cheap. It doesn't need anybody to take blood from a vein, so it can be done by people without that training. And in many respects, TST is a very useful test because it does tell us what we really want to know, which is who are the people who are going to benefit from receiving TB preventive therapy. Lots of evidence, which I'll touch on a little bit later. But of course, there are also quite a lot of disadvantages of TST. It's operator dependent. Obviously, it needs there to be tuberculin, and quite often there isn't tuberculin around to be used in that test. You've got to have a second visit in a relatively narrow time window, which can be difficult. And other difficulties including that if you're HIV positive with low CD4 counts, then you may get a false negative, and then you've got the problem of loss of specificity, so you can also get a false positive if you've had BCG, particularly relatively recently, and you've got the potential for boosting if you repeat the test. The slightly newer methods for diagnosing latent TB, the immune gamma release assays, or IGRAs, do have some advantages. They're less operator dependent. You don't have to have this return visit within the strict time window. You don't get cross-reactivity with BCG. and you don't get the problem of boosting. But relatively speaking, they are expensive, they need laboratory facilities, and of course it needs venous blood, so not perfect, particularly for resource-limited settings. And I think really the problem with both of these tests is that neither of them are really very good. So if we look at how good each of these tests are at identifying people who are likely to progress to active disease, they do give us some indication, but neither of them are ideal by any means. So this is a meta-analysis done by Leila Rangaka and colleagues, and what you can see is that overall the pooled estimate for the incidence rate ratio, so that's comparing people who are IGRA positive to people who are IGRA negative and saying how much more likely are you to progress to TB if you're IGRA positive compared to IGRA negative. And so the pooled point estimate on that is just over 2, so you're about twice as likely if you're IGRA positive. And if you're TST positive compared to negative, and here are two different cutoffs, 10 millimetres and 5 millimetres. So there, the point estimate's slightly lower, but wide confidence interval. So we can't really be very sure that IGRA is a lot better than TST. And I think the bottom line is that neither of them are particularly good. And one of the difficulties is that even if you've got a positive test result, your probability of progressing to disease is relatively low. So this is from the same review, and this is looking at incidence rates for people who are IGRA positive versus IGRA negative in studies where these have been compared, and just noting these incidence rates are per 1,000 person years. So even if you're IGRA positive, your probability of progressing is not that high. And the bottom line is that greater than 95% of people who are either IGRA or TST positive are not going to progress to active disease. So the positive predictive value of either of these tests is relatively low. So what's new with respect to diagnosing latent TB? Well, firstly, we've got another new actor in the quantiferon stable. So we had quantiferon gold before, and now we've got quantiferon plus. So quantiferon plus has an extra tube, which is called TB2, and this is designed to elicit an interferon gamma response from CD8 cells rather than CD4 cells, which the previous one was particularly focusing on. And this CD8 cell response is believed to be particularly important with respect to identifying recent TB infection, and that's important because people who've been recently infected are more likely to progress to disease. And also it's designed to be better for people who are HIV positive, who may have few CD4 cells, and also children. And just very recently, there's an item in press which is evaluating the quantiferon plus test, and here's some results here. So it was evaluated in adults who had bacteriologically confirmed TB compared with controls, and the controls were healthy Italian students. And so what you can see is with the quantiferon plus, the sensitivity in the TB patients was nearly 88%. And that compares with a sensitivity of the previous quantiferon of around about 80%. So in terms of sensitivity, it's a bit better. But still, this is not exactly a step change in terms of the diagnosis of latent TB. So maybe we're looking in the wrong place, or maybe we're asking too much. I mean, if it is the case that people with latent infection are unlikely to progress, perhaps we need to look somewhere else. And I think that there is increasing acceptance of the idea that we don't really have two binary compartments. We don't have latent TB and active TB, but rather there's a spectrum, and this is illustrated rather nicely by this diagram, which is from a good review by Hanif Esmail. And so perhaps if we're looking at these people with latent infection, maybe that's not the right place to look, because what we really want to know is who are the people who are going on to develop active disease. And in fact, I think we've known for a long time that this subclinical phase of active disease is really quite long, particularly in HIV negative people. So how about if we start looking at ways to identify people with early disease rather than strictly latent infection, whatever that means. So I think there's some exciting work going on in this area, and particularly looking at biomarkers. So we can think about interferon gamma perhaps as one biomarker, and I think there's a range of different approaches, and I've just illustrated this with one study which is looking at transcriptomics, or so gene expression signatures. And I think the idea here is that rather than just look at one marker, can we look at a whole range of different markers and try to look at a pattern which is particularly associated with TB disease rather than people who are not going to progress to TB disease. And in fact, I believe next week in The Lancet, a paper which has examined this in a cohort of adolescents in Worcester, in the Western Cape of South Africa, that's going to be published, and they have a signature which seems to be associated with active disease. And this is then going to be tested, because obviously it's all very well to have that, but what we want to know is then, can you put that into practice and can you use that to prevent disease? And so the idea is that this signature will then be tested in adults, in HIV-negative adults, to see whether testing and then treatment can prevent active disease. So I think this is a very exciting development, and we can think of perhaps several different ways that that could be used. So moving then from diagnosis and thinking about treating latent TB, so again, just starting with what's old, so our standard is isoniazid preventive therapy, and the idea for this really came from an observation in the early 1950s when isoniazid was first used, that children who had miliary TB who were treated with isoniazid did not go on to develop TB meningitis. And from this came the idea that isoniazid could perhaps be used to amongst people who had asymptomatic TB infection to reduce the risk that they would then go on to develop disease. Now, isoniazid works by inhibiting cell wall formation, so it's only bactericidal in dividing cells. In latent infection, as we understand it, there's a low rate of cell division, and so if you were designing a drug to treat latent infection, you would not start with this one, because it really doesn't make sense. On the other hand, despite it not making sense, it seems to work. So it's been very well studied, and I'll show you some of the evidence for that in a second. It's generally quite well tolerated, and it's very inexpensive, and it's got a very well recognized side effect profile. So again, just to summarize some of the data in terms of efficacy, this is a meta-analysis of clinical trials focusing particularly on people who are HIV positive and comparing people who received isoniazid for a limited, usually a 6-month course, compared with controls. And so overall, people who received isoniazid had around about a 1/3 reduction in their risk of developing TB compared with controls. But a very big difference between the effect in those who were tuberculin skin test positive, where we have a much bigger effect, compared with those who were skin test negative. So again, just illustrating the point that TST, for all its faults, does tell us what we want to know, which is who's going to benefit from receiving treatment for latent infection. It's also just interesting that this is about a 2/3 reduction, 64% reduction, but it's not a 95% reduction. So even though isoniazid works to reduce the risk, it doesn't reduce the risk to nothing, which is interesting. So in low TB transmission settings, as we said, most TB disease arises from reactivation of latent infection. Treatment of latent infection, or managing this burden, is going to be central to TB elimination. We've got isoniazid, which is classically given for 6 to 9 months. That's quite a long time for healthy people, and usually completion rates are rather disappointing. So shorter regimens would be preferable if they were effective and safe. So thinking about what's new, so I think perhaps the major news over the last few years on this has been a study looking at a novel regimen of rifapentine, so a long-acting rifamycin in combination with isoniazid, and that was compared in a large study led by Tim Sterling to 9 months of isoniazid. So this rifapentine isoniazid regimen was given weekly for 12 weeks as a directly observed therapy, and that was compared to daily isoniazid self-administered as the standard of care. So this study was done in nearly 4,000 people per arm, largely in the US and Canada. Very few HIV positive people were included. That wasn't intentional, that was just how it worked out, which was a limitation. And as you might expect, the completion in the rifapentine arm was much higher. Unsurprising, it's shorter, and also it was directly observed. So the results of this was a non-inferiority trial, and indeed the rifapentine arm did meet the criteria for non-inferiority, and in fact it looked like it might even be a little bit better, and it was very well tolerated. So rifapentine and isoniazid, a very promising regimen, shorter, better tolerated, possibly even a little bit better. So a very useful new tool in the armamentarium. As I mentioned, one of the limitations with that study was that there were very few HIV positive people, and clearly we're very interested in regimens for HIV positive people because of their higher risk. So the study was extended to specifically recruit more HIV-positive people, and I can't find the efficacy results on this. I don't think they're out yet. But just looking at the safety, I think you can certainly say that it is at least as well tolerated as isoniazid amongst HIV-positive people. One of the limitations, or one of the criticisms perhaps of that study, was that it was given, that the rifapentine isoniazid combination was given as directly observed therapy, and many people feel that that's not something that would be easily translatable at a wide scale. So another study by the same team looked at comparing this regimen as directly observed therapy, as per the previous trial, with the same regimen self-administered. And this was a smaller study with nearly 1,000 people, mostly in the USA. And there were 3 arms. They were comparing the directly observed regimen to self-administered without any support. And a third arm was what they called ESAT, so that was self-administered with an SMS reminder. And these results have not been published in full either, but there was an abstract presented last year at the CROI conference. And so what you can see here is that completion in the directly observed arm was 87%, pretty good, as you might expect. The self-administered arm was not quite as good, but was within, and overall was not within the non-inferiority margin. But then within the US, it did meet the criteria for non-inferiority. So the recommendation that's come out from that is that it's all right to self-administer in the US but not elsewhere, which is a slightly interesting conclusion. So we're awaiting the full results of that. But I think it does give the impression that self-administered therapy is unlikely to be taken quite as well. And maybe that's not surprising because this can represent a very large pill burden. Unless you can get combination tablets, you're required to take at least 9, and then plus the pyridoxine. So that's going to be probably some more tablets on top of that. It is a pretty hefty pill burden to be taken, even though it's once a week. And combination tablets would definitely help a lot with that. What other shorter preventive regimens do we have out there? So there are 2 other studies which have been running for quite a long time, and which we should be seeing results fairly soon. So one of them is comparing a 4-month rifampicin-only course of treatment compared with the standard of care of 9 months of isoniazid, and that's in adults in high and low prevalence settings, and that should be due to complete this year. And then there's another interesting study, which is an ultra-short course regimen of rifapentine and isoniazid given daily for 1 month, compared with 9 months of isoniazid. And that is specifically being done in high-burden countries. And the results of that will be available next year. So what about high transmission settings then? So here we have not only the issue of the reactivation of latent infection, but in addition, because of the high prevalence of TB, we've got a lot of reinfection going on, so it's a bit more complicated. And here in high transmission settings, clearly shorter regimens would also be desirable. We've got the tension because of the risk of reinfection that a longer regimen might well be better. And so what's the evidence on this? So this was one of the studies that's looked at this perhaps in most detail is this large study from Botswana comparing 36 months of isoniazid as a surrogate for continuous treatment to 6 months as a standard of care. And this was amongst HIV-positive people. Mostly female, wasn't restricted by skin test positivity, and only about 25% of people had a positive skin test. Median CD4 count at the start of the study was around about 300, and about half of the people started antiretroviral therapy during follow-up, and this study was done during the noughties, and so at the beginning of the study at least, the criterion for starting antiretrovirals would have been a CD4 count of 200. So we've got shifting guidelines also during the period of this study. And so what did they find? Well, during the study, they found that, as expected, 36 months of isoniazid was better than 6 months of isoniazid, and there was a 43% reduction in TB incidence during the trial. However, disappointingly, what they found was that after the end of the trial, those people who'd taken the 36 months of isoniazid did not get any lasting benefit. So that protective effect went away pretty much immediately. So isoniazid works while you're taking it. And that's quite similar to the results of another study. This was done in South Africa, looking at a range of different regimens, including also the rifapentine regimen that has been described before. So 4 different regimens, rifapentine isoniazid, rifampicin isoniazid, continuous isoniazid, and 6 months of isoniazid. And in the intention to treat analysis, really nothing to see in terms of difference. But in an attempt at an as-treated analysis, where people were censored if they stopped their treatment, what you can see is that this solid line, which represents the continuous isoniazid arm, does look as if it's doing a bit better. And I think part of the problem was there was a lot of dropout at the end of the study. So a lot of people dropped out. And so while people were taking their isoniazid, you got the impression that they were protected, but not if they stopped. And one further illustration of this issue of the short durability of isoniazid comes from a study that I was involved with, the Tibella TB study, where we were trying to do a rather heroic intervention to interrupt TB transmission in the challenging setting of the South African gold mines, where we had enormously high TB case notifications despite really quite active TB control, including annual active case finding using radiological screening. And so what we were trying to do here was to give isoniazid not just in a targeted way, the way that you usually would, where you're targeting high-risk individuals, usually people who are TB contacts or people who are HIV positive, but rather saying, well, everybody's at risk, so let's just treat everybody. So the idea with this study was that we would screen entire populations, so entire workforces, up to about 11,000 people in some of these mining workforces. We'd screen everybody for active TB. If they had active TB, they'd go on to treatment for active disease. If they didn't, they'd get treatment for latent infection. And so we did this in 15 gold mines, about 80,000 people in total, and disappointingly did not find an impact on TB incidence or prevalence at population level. So one of the first things that one of our senior advisors said was, are you quite sure that there was some isoniazid in those tablets that you were using? So good question. So to look at that at an individual level, so this was an analysis, a post hoc analysis, to look to see whether people who actually took isoniazid did better than those who didn't. So based on our baseline surveys, a sample of people within each of the clusters, and looking at people in the intervention clusters who actually started isoniazid, that's 4,500 people, compared to people in control clusters who didn't take isoniazid. And what we found was that while people who did take isoniazid, while they were taking it, had a large reduction, a 63% reduction in TB incidence of the order of magnitude that you would expect. But that effect went away pretty much immediately afterwards. So again, another piece of evidence suggesting limited durability of isoniazid. And another interesting thing that came out of this was work done by our mathematical modelers led by Emilia Vinicki. And I'm not going to talk you through the mathematical model because I would do that really very badly, but just to try to give you an idea of what was interesting about this. So one of the things the first thing that the modelers tried to do was to get the model to reproduce the data that we actually found. So, and obviously there had to be some assumptions in there, and one of those assumptions was that giving 6 months of isoniazid would cure latent infection. And what they found was that if they put that assumption in, they couldn't get the model to fit the data. So if isoniazid did cure latent infection in this population, we really should have seen an impact. And the only way that they could get the model to fit the data was that they assumed that 6 months of isoniazid did not cure latent TB. So that's interesting, and I think that's sort of, there's been since then quite a bit of work, and Ryan's done some work on that as well. You do get the impression, perhaps we could explain this by suggesting that people who've got a very heavy burden of latent infections, such as somebody who's a South African gold miner might, maybe 6 months of isoniazid just isn't enough to clear that. All of this has led to guidelines recommending continuous IPT. So these are the most recent WHO guidelines about case finding and isoniazid preventive therapy, which make a conditional recommendation for continuous IPT for HIV positive adults who've got either a positive TST, in which case the evidence is pretty good based on that Botswana study, or if they've got an unknown TST. And that's really because implementation of TST is so difficult in resource-constrained settings. there is difficulty with implementation of isoniazid, and that's led to thoughts about, well, what about this shorter rifapentine regimen? So a study that we're developing at the moment is to look at comparing a single course of rifapentine isoniazid, the same regimen I described, with a pulsed course to see whether you get benefit from a second round or not, and to look at the durability. So the final thing that I was just going to say was that antiretrovirals are also an important way of preventing TB reactivating, around about a 2/3 reduction for people taking ART compared with not. And a nice study again by Lelia Rangaka, a randomized controlled trial showing that isoniazid adds to the effect of antiretrovirals. So good evidence suggests that those two should be used together. So just to wrap up then, I think, where are we going with this? So I think in low transmission setting, I'm very interested to see how this biomarker data will come out, and to think about how we may be able to use biomarkers to target the treatment of early disease. And also, another question is, well, will these shorter and safer regimens be more widely used? In high transmission settings, I think we still need to decide what's the best strategy, and also we need to think about how we're going to integrate TB prevention with HIV care. Thank you for your attention.